Okay, so good evening to you all on this masterclass of pharmacy practice. So I would like to acknowledge ISF College of Pharmacy, its management, its chairman, director, principal, Choti's staff members, and all the participants, wonderful participants in this lecture series of masterclass. So particularly today we're going to discuss about therapeutic drug monitoring, and therapeutic drug monitoring is particularly uh, one of the segment where we need to understand that we are going to check the efficacy of the drugs which are in therapeutic in nature and being used. So one of the most concentrated proportion in the pharmacy practice is at a concentrated level therapeutic drug monitoring. So today we're going to discuss about this therapeutic drug monitoring in detail, and in this context we need to see that this therapeutic drug monitoring as a part and parcel of the medicaments, the therapy, the various aspects of life-saving drugs which therapeutic window needs to be checked. So therapeutic window, when we are judging, when we are looking for the concept of therapeutic drug monitoring, it is very important to see the clinical pharmacokinetic and therapeutic drug monitoring of the proportions. In that context, I would like to ensure that this lecture is going to be very beneficial in terms of the knowledge aspect. So, therapeutic drug monitoring is one of the concept in India being used in pharmacy at NABH accredited hospitals, particularly where the medicines which are having the narrow therapeutic window and they are life-saving medicines. So based on to the T half and other pharmacokinetic and dynamic properties, we judge with the medications part and their aspect. So this is very one of the best thing where we need to understand when we need to see that the molecule is in the compilation. So therapeutic drug monitoring. What is therapeutic drug monitoring? Therapeutic drug monitoring refers to the measurement, interpretation of principally blood or plasma drug concentration measurements with the purpose of optimizing a patient's drug therapy and clinical outcome, while minimizing the risk of drug-induced toxicity. So we need to understand that several medicines are there which are intended to understand that we need to estimate that in this particular segmentation, this measurement of the medicine and the purpose of optimizing a patient's drug therapy and clinical outcome while minimizing the risk of drug-induced toxicity. So therapeutic drug monitoring means when we are seeing a therapeutic action, therapeutic drug planning, and in this therapeutic drug planning we are giving the medicines and it is changing some physiological functions in the body at blood and plasma concentration level. So our pharmacy practice governs not only with the clinical prospects but anatomical, preclinical, pharmaceutics, and other various domains where we need to see as a R&D aspect. So therapeutic drug monitoring refers to the measurement of drug concentrations in biological fluids with the purpose of optimizing a patient's drug therapy, and during administration of a dosage regimen the concentration should be maintained within a therapeutic window. So the TDM refers with the T half as well as the dose, where we need to understand that an individual personalized medicine, individual profile, where the amount of blood, amount of medicine, amount of time, which covers with the loading dose. So as you can see that in our current era in the therapeutic drug monitoring, we are having the various methods of chromatography, immunoassay, biosensors, capillary electrophoresis method, spectroscopy, chromatography, and in the various drug category like anti-epileptic drugs, immunosuppressive drugs, antibiotics, antifungal drugs, antipsychotic drugs, cardiovascular drugs, anti-cancer drugs. So the types of drugs commonly used clinically for TDM. So in this you see that once the sample is collected, it go for the analysis, the biochemical, hematological, radiological interpretation is done, And then it goes to the core clinical values with the medical judgment, adjustment of doses, chromatography, immunoassay, sensors, and wearables. These are the types of the things which are really in the requirement of proportion nowadays. So if you have sophisticated assemblies machines where you are doing this, and this helps very much effective in the establishment of rational drug therapy, rational drug use, as well as evidence-based medicines. So what is the process of therapeutic drug monitoring? We need to see that what is the level of medicine in the blood, its biological samples, a request form, laboratory management, and the result communication by a laboratory for the clinical interpretation, which leads to a strong establishment of standard treatment guideline and management and treatment of certain diseases. So the therapeutic range or the therapeutic window, this therapeutic range or therapeutic window is the concentration range of drug in plasma where the drug has been shown to be efficacious without causing toxic effects in most people. And toxic range, therapeutic range, subtherapeutic range, we need to understand that at the serum concentration T half level, as far as the therapeutic range and the toxicity at the some life stage, it should be there. So what is the requirement, basic requirement for doing such kind of therapeutic drug monitorings? So first we need to understand the drug profile. Every medicine has a drug monograph and drug profile being published in Pharmacopoeia and National Formulary of India. So we need to see that the medicines which are having low or narrow therapeutic index, for that medicines we have to make the changes in the concentration. Okay, so when it goes to the acidic media or concentrated media inside the plasma protein levels and tends to bind, then it makes a change in the drug's response. So drugs which have poor absorption rate or drugs which vary in terms of pharmacokinetic variability or variation for the metabolism process. Next is the patient which are having some toxic signs or effectivity like theophylline intake or persistent nausea. So any drug allergy history or certainly any kind of symptomatic alliance which are requirement for therapeutic drug monitoring. To minimize the risk of toxicity, to identify that the poison and to determine the severity, drugs where signs of overdoses or underdoses are difficult to distinguish. Drugs which are administered in the presence of GI, hepatic or renal diseases. When patients are receiving multiple drug therapies. Now next is what are the various other drugs which are not suitable for therapeutic drug monitoring, like which drugs which are having narrow therapeutic window, and we are the one this in this concentration we need to check out in this, like I have got one chat box query. Drugs for which small changes in the concentration of drug in plasma are likely to exhibit large changes in the drug response. It is just like non-linear kinetics, and into it the example is artemisinin and sulfur drug or anti-malarial drug, quinoline derivative. If we increase a little bit T half of artemisinin, we will come to know the prophylactic and the incubation period will be reduced of the deadliest disease malaria. So this is the explanation for the second point. And drugs having wide therapeutic index like non-steroidal anti-inflammatory drugs, then toxicity is not a realistic concern. Suppose if I say about the at the concentration level, if I ask about the concentration where the toxicity is not a concern. So genotoxicity, ICH guidelines, in which we need to see that ICH gave various guidelines regarding to carcinogenicity and toxicity, battery test, M test is performed. So in this particular category, I need to understand that whensoever we are concentrated with the level of the molecular pathway, we need to understand that some medicines don't have that much toxic action or toxicokinetic profile which may affect the perception. So in this concept, we need to see the toxicity, profiling and toxicity. So for that, a toxic dose is defined. Effects which can be measured using functional laboratory tests like anticoagulants, oral antidiabetics, antihypertensives, etc. Plasma concentrations not predictably related to effects like anticoagulants, and effects of the relationship remains undefined like antidepressants, hit and run drugs like omeprazole, MAO inhibitors, some medicines with narrow therapeutic index. These are the examples where you will understand that at a particular set of action where you have to see that you are looking for the molecular pathways, and in this molecular pathway the theophylline, gentamicin, amikacin, vancomycin, which are in the list, are likely to have concern with this activity. Now, these molecules are used as for the purpose of life saving. In crash card or emergency medicines, in clinical profiling, you will find these molecules to be very effective. So I need to understand that in this concentration, the concept of probability of having toxic effects. So immunosuppressants, antibiotics, antimicrobials, anti-cancer such as methotraxates, and anti-epileptics such as phenobarbital, phenytoin, valproate, cardiac drugs, digoxin, procanamide, lidocaine, psychoactive drugs such as lithium, part of this whole series. So psychoactive drugs like lithium and heavy metals are certainly with the concentration indexing into it. Then one more examples of such medicines are the glycosides, specifically digoxin. As you know, this medicine is widely used in world for in the emergency department, which is given IV or orally, where the plasma concentration and the response relationship of a graph of drug levels. If it is in the less amount, 0.5 microgram per liter, then no clinical effects are observed. But when some level is increased or titrated, some positive inotropic effects comes. So similarly, in a therapeutic range, not more or not less. So that is called as the optimization of the therapy. If that optimization is done particularly, there is a chance that there will be lesser amount of activity. So toxicity or negative activity. So increased risk of toxicity, and certainly if the dose is more titrated, then you will have CNS, CVS, GI toxicity also. So why I'm telling these things with the examples of narrow therapeutic effects or the digoxin, because it is worldwide use. So at the concentration level, we need to see this activity as a whole. So now moving forward, we need to see that in this understandable task, various factors which affect therapeutic drug monitoring. Like first is patient demographics. So age, sex, lean body weight are particularly important for renally clear drugs, as knowledge of this allows calculation of creatinine clearance. Patient's compliance, if the concentration of the drug is lower than expected, the possibility of non-compliance should be considered before a dose increase is recommended. Then individual's capacity to absorb. So PK/PD profiling of each individual is different. As you know, patient, their makeup, their bio makeup, and their pharmacokinetic variation is one of the important thing, in which ADME everything is different. So certainly the rate of absorption, extent of absorption is dependent on several factors like the drug formulation, manufacturer, route of administration, intra-individual variation. Another aspect of absorption is bioavailability. So the T-half. So what happens when the fraction of administered dose that reaches the systemic circulation, bioavailability is 100% for IV injection. Then distribution, volume of distribution, dose by plasma concentration. So the absolute bioavailability of a drug. So by this bioavailability, the expiry date of the medicine is fixed. So if I say in your stomach the media is acidic at 100% concentration, if any medicine goes and it goes inside the stomach, it get absorbed, and free drug and the API drugs visits go to the different receptors and parts of the body and get and logged into the other proportions, and certainly gives the therapeutic activity. So in this, the determination, the correct drug dose route is required to attain the desired therapeutic range. So the volume of distribution, dose, plasma concentration is an important parameter. Metabolism. So metabolism is divided into two parts now: anabolism and catabolism. Phase 1, phase 2 conjugation, oxidation, reduction processes, 6 splits, where the protein binding is divided into bound and free part. It means the inactive and the active. So the drug doses will depend on how the drug metabolizes. What is the time required to get that metabolism done into the body? So the drug that metabolize include various factors such as genetics, environmental, nutritional, and like certain drug properties having any kind of incompatibility. So drug interaction may happen, then the body capacity as per the age. So the vitality of the body is another function, body surface area, maturity onset. Next is the elimination or the excretion of the drug from the body, which occurs through the kidney, fluids, excreted through the lungs, GI, or skin. So renal dysfunctions, which reduces drug clearance and may contribute to drug accumulation and increase risk of adverse drug effects. So other causes like age in general, drugs metabolize more slowly in fetal, neonatal, or geriatric populations because the basic metabolic rate is quite slow or not that much fast as compared to the adults. Physical properties of the drugs like hydrophobicity, partition coefficient, solubility. So if the drug is administered in a fed or fasted state, gastric emptying rate. Enzyme induction or inhibition by other drug or food like phenytoin, barbiturates, carbamazepine, and various antituberculins and cytochrome series which involve drugs metabolism reduced activity. So enzyme inhibition decreases the rate of metabolism. And the fifth is concomitant disease, tropical disease, or nutritional deficiencies, which includes highly prevalent in developed countries like infections, diarrheas, worm infestations, tuberculosis, nutritional deficiencies, and higher proportion of patients with diabetes and AIDS. Then whereas when we use the polypharmacy or the alternative medicine system, when we mix up the therapy like Ayurveda, Allopatha, along with or Unani, Siddha, and allopathic medicines, when we mix up the holistic medicine with the Western medicine or the English medicine, so there is a history of generalized tonic-clonic seizures and many more activities increases where the dopamine, oxytocin, serotonin, norepinephrine level is increased. So where the therapeutic role presents into various other activities, locomotor activities such as seizure problem. Then another thing is the alcohol and the tobacco use. So when it use the chronic use of alcohol is shown to have hepatic microsomal enzyme induction, resulting in increased clearance and decreased urine concentration of hepatically cleared drugs. Another example for the factor in is cigarette smoking, which increases the hepatic clearance of theophylline, and patients who have recently stopped smoking may have unexpectedly high theophylline concentration. And next is the medication or sampling errors. In cases where the TDM result is incompatible with drug administration records, the possibility of a medication or sampling error should be considered. The drug may have been given to the wrong patient or blood mistakenly. So this due to medication errors or sampling errors. In laboratory errors, samples may be repeated for the assay, or a new sample can be drawn for assay. Then the cost effectiveness, another factor is So rapid and cost-effective environment of most drugs for which TDM is indicated can be achieved using commercial kits runs on automated analyzer using a number of different methodologies, including fluorescence, polarization, immunoassay. In testing methodology, as I already told, HPLC, various sophisticated machines are being used. So for doing at a clinical level, a therapeutic drug monitoring, you should have a request form, which include the personal demographics, patient name, age, sex, gender, height, weight, ward, or by whom it is ordered, then the drug level, and also the time and date, and when the therapy started, date, time, route, IV, IM, subcutaneous, per oral, dosage form, time, dose, frequency, drug level, or sampling, time, thorough or predisposed, level, time, peak level. Does the patient have organ system damage, renal, hepatic, cardiac, GI, endocrine, other drugs patient is taking, drug level, usual therapeutic range, technologist, chemist, into pharmacist, pharmacokinetics, pharmacologist, date time, etc. So in the whole this TDM process, a decision to do check the level, the biological sample with the laboratory, confirmation of the communication of the results, and clinical interpretation leads to a therapeutic management. So in India, if you see in the November, this was the population. So certainly you are able to understand the integrated disease and demographic cycle and various prevalence rate of the diseases. So India is a huge population where a lot of healthcare providers requires in rural areas such kind of shortage of medical professionals. So 74% of doctors are in urban areas that serve the other 28% of the population. This is a major issue of rural access to healthcare. In such condition, therapeutic drug monitoring in such advanced access and clinical practice is not done. There are various challenges in India to perform the therapeutic drug monitoring. Lack of scientific accuracy of drug assay, lack of healthcare providers, overburdened in terms of population, poverty in the India, lack of facilities and equipments in hospitals, expensive therapeutic drug monitoring process, no recruitment of therapeutic drug monitoring process team in Indian hospitals, clinical challenges in therapeutic drug monitoring, like special populations, like physiological conditions, pharmacogenomics, focuses on critical issues in therapeutic drug monitoring, including special requirements of TDM, and in infants, children, pregnant women, elderly patients, obese patients. Difficult to identify the special population in Indian population. And whereas some drugs where we can perform the therapeutic drug monitoring are the anti-epileptic drugs, phenytoin, phenobarbital, benzodiazepines, carbamazepine, valproic acid, ethosuximide, antimicrobial agents, aminoglycosides, antineoplastics, methotrexate, bisulfan, 6, cardioactive drugs, amiodarone, digoxin, digitoxin, immunosuppressants, cyclosporin, tacrolimus, sirolimus, antidepressants, lithium, tricyclic antidepressants, theophylline, caffeine, etc. So every molecule have their effects and have their mechanism of action, and they all are done in a particular state. So phenytoin is the most commonly used anti-epileptic drugs. It is a selective anti-epileptic effect and does not produce significant drowsiness. So what is the mechanism of action? Phenytoin acts by stabilizing the neuronal membrane and prevents spread of seizure discharges. The sodium channel exists in three forms: resting, activated, and inactivated states. So the phenytoin delays recovery of sodium channels from inactivated states, thereby reduces the neuronal excitability. At high concentration, phenytoin inhibits calcium influx in the neuron, reduces glutamate levels, and increases response to GABA. So where you can see various examples, either it is phenytoin, toxicity, or various other things. So not only this, but heavy metals and with their examples we can go with the therapeutic monitoring of aminoglycosides, theophylline, etc. So there are various molecules which have their clinical pharmacokinetic activities affected. So I hope today's lecture have enriched your knowledge in terms of therapeutic monitoring process. So now I would like to ask if there is any questions, and confirmed as by Dr. Abhishek Vijay Kumar, there is no such questions. So thank you so much for joining you all guys on this YouTube live, and tomorrow we will be meeting on the same time, 7 o'clock, and we'll be coming with the lecture number 15 and 16 of this series. Till then, thank you so much, all of you.